everyone. I'm Ellie from Nourishment Redacted. So happy to welcome you to a special episode of Lioness Lifestyle Live.
Yeah, a bunch of weird stuff going on. It's a Monday. I'm in my bedroom. But that's all right. I'm Cristie from Wellness, and I'm so excited to meet you. Thanks for joining us this evening.
And I'm Hayley from MeatisWhereItsAt. Get those questions ready for our guest because you are going to want to ask some, trust me.
That means it's time for this week's Roar of the Week. We had Sana on last Tuesday for Mrs. Perfectly Imperfect Keto. And what an amazing story, right, you guys? So every week we so love going through the comments that you guys leave us after the show is over. And we find one that we would like to shout out. So after the stream tonight, make sure you leave your comments so I can do this maybe for you next week. But this week's Roar of the Week is from Carl's app. A5177. It would help if I could read. I was in jury duty for 9 hours today, ladies and gentlemen.
So glad you're here. Welcome back.
Yeah, I just made
to the real world.
I know, right? Great story. You ladies are pretty cool. And then all the meat, salt, like sun, butter, egg, all the good emojis. So I love that one. Thank you so much, Carlos.
So I think we all are. We are so beyond excited to invite our guest onto our show. Let's invite her right now. Hi guys. Welcome, hi, Dr. Salcedo, otherwise known as the Conscious Gynecologist, which I love your handle. That is so amazing. We're so happy to have you on the show. If you could please tell us about yourself, your expertise, and why you believe low carb is best for metabolic health. I'd love to get into all those juicy details.
Oh, great. Well, thank you. It is such an honor and to be working with such trailblazing women, turning a consensus on its head, what we know to be true, and really just helping women. And that's my life's work. I am a generalist OBGYN, full scope. I deliver babies and do full scope gynecologic surgery. I'm a mom. I'm also a wife, and I live in Southern California. I work at Loma Linda University Medical Center, and I teach medical students and resident physicians, and I have patients. And it's just a wonderful, thriving practice. And a lot of that has to do with my more specialized approach. I definitely approach gynecologic health in a little bit of a different way, all based on science, all based on really great literature, and but also something a little different. I do a lot of metabolic health work, and I use this work to teach other health practitioners, doctors, health coaches, nutritionists, how to teach and treat how to treat gynecologic problems with nutrition and lifestyle, because really what we're all looking for is to avoid medications and surgery, and we're all really trying to have a normal feminine life. And so that is my goal, and that is really the purpose of why I deliver babies all night long and I do long surgeries, just so that I can really do help women and have that focus and understand truly what a gynecologist's role is for helping women. So that's what I do, and that's what I'm about. I also do a fair amount of clinical research too, where I try to publish literature in the academic journals to teach other doctors, not just through YouTube, but also through the published literature and peer-reviewed journals, so that we can continue to legitimize what we as women know in the low-carb space.
Well, that was a lot. That's a lot that you do, Dr. Salcedo. I don't know how you do it all. I thought we had a lot to do as a mom, a teacher, and YouTuber, but you got me beat, I think. I actually have a question about the research you mentioned. So the research you mentioned, like, has any of it been into like low carb eating and how that affects women, like with, I don't know, PCOS or any of those type of issues?
Yeah, so the interesting thing is that one of the biggest common gynecologic problems that women present to us doctors is something called polycystic ovary syndrome, which has to do with like irregular periods and maybe hair where you don't want it, and sometimes infertility. And so it usually plagues women kind of earlier in the reproductive life. But the interesting thing, and the reason why I brought it up, is according to the American College of OBGYNs, which is like the big organization that helps give us guidelines on how to treat women, says that lifestyle should be the first line in treatment of polycystic ovary syndrome. But even before it turns into PCOS, a lot of ladies tend to have irregular periods. And so truly, truly, if a woman is having an irregular period, there is something wrong. And I think we all kind of know that, right? It's either like, evolutionarily, our brain is like, uh-oh, what's wrong? Am I pregnant? And if I'm not pregnant, what is wrong, right? And so that inherently is something that we know in our heart, in our gut. And so if American College of OBGYN says that lifestyle should be our first line in treatment, well, unfortunately, for many years, the lifestyle advice that we had from big nutritional bodies and how to take care of ourselves as women was not exactly sound. The literature wasn't great, and it really brought us into a worsening nutrition and metabolic health disorders that led to obesity and diabetes and hypertension and stuff. And so a lot of the advice that we were giving folks was not great advice, but truly, if we look at the physiology of polycystic ovary syndrome, it has to do with high insulin levels. And there are many things that cause elevations in insulin levels, but sugar being one of them, and carbohydrates. And so what I do is try to bring that to the forefront of how we take care of women. And I actually just wrote a paper back in August. It was actually an opinion paper for other healthcare practitioners to really see how therapeutic carbohydrate restriction can be the first line in treatment of many gynecologic disorders. And I laid out the pathophysiology based on excellent science and things that we've known for decades. The really interesting thing is that hardening of the arteries, which we know as the word atherosclerosis, right? So the hardening of the arteries, our arteries are made of the same smooth muscle that's found in our uterus. And so when ladies get a little older, they start to develop something called fibroids. And so when I talk to women about their irregular periods or heavy painful periods, I actually tell them that fibroids are just another sign of hardening of the arteries, which is cardiovascular disease. And that's really interesting. And we've known that since the 1960s. And so a lot of the research that I do uncovers old pathology papers, scientific papers of folks who weren't necessarily driven by pharmacology and surgical technology to bring it to the forefront to remind us gynecologists really what is the pathophysiology here? How do problems come about in feminine life? And then what solutions can we take that don't always involve medications and surgery? So my most recent paper does talk about that.
That's amazing. So how much nutritional advice are you, I don't know if allowed is the right word, but allowed to give? And do patients take you up on that very often?
Yeah, so it really depends on the patient, right? Because as much as I'm like a low carb advocate and very much interested in helping women with understanding that lifestyle, it really is up to the patient. And so I think a good doctor should talk about lifestyle, medications, and or surgery if it applies, right? And then the patient gets to decide. And so no, there is no like, are you allowed or not for me? Because a good doctor, a good physician should know all three of those modalities. And then once you know them, then you feel very confident with guiding someone towards the solution based on what they want. Now, certainly there are so many women, and unfortunately there are many women that have really heavy periods. They need blood transfusions and, you know, those kinds of things. And so, of course, like, we want to stabilize them with medications or surgery, but we also, is our responsibility as doctors to teach women how they got there, right? And so maybe if, you know, just because I can do a hysterectomy or treat someone with medication doesn't mean that I shouldn't give them the understanding and the opportunity of how they got there. And just to say that ladies are like, oh, well, you're a woman and you have hormone problems and stuff, that's actually not fair. And that's almost a little bit mean to say to someone, right? You know, because the hormones that are affecting a woman is actually insulin, right? It's actually elevations in insulin that cause all of those damaging effects that lead to changes in our feminine hormones. So I love teaching women that. I love sharing and discussing the options, you know, and then truly they get to decide.
I love that. I I joked with my husband. I'm religious, and I would joke with him before I found carnivore and had all of these issues, these, irregular period, really heavy, painful. I'm going to have a chat with God about why he made it so that women are like this. And now it's like completely opposite. Like, of course, if you're religious, he didn't make you like that. I mean, we're not supposed to live like that. And so I love that you advocate for your patients in that way and give them all of the options. And then whether they ask you, which one do you think I should do? Or they go back and, investigate themselves and then pick which one they think is best for them. I think that's amazing. And someone said here in the comments somewhere, where is it? Let me know where I can find that kind of doctor.
Oh man,
So,
my work is done. Thank you very much. That's like the best thing I heard all day.
You gotta move to where she's at. That's what you gotta do.
Southern California, Maribel, right here in Southern California.
Yes. But I also had a question for you. I have an 8-year-old daughter, and she's kind of starting to grow up a little bit. And I have history and family members where they start their menstrual cycle quite early. And like, I guess I say early based on my own knowledge of what early is. But I was wondering, based on your professional opinion and like everything that you know and have experienced, what is the right age? What is a normal age range for a woman who's metabolically healthy, for a girl, I should say, who's metabolically healthy to start her menstrual cycle?
Yeah, so on average, the menstrual cycle should start around age 12. Okay. But there is a wide range of what is considered normal. So if you remember, like, your bell curves, right? And so, lower, like younger than 9 is a little bit unusual. And then above 14 to 16, depending on if you have breast development, it becomes a little bit unusual if it doesn't start until then. And so anything in between is considered normal. Now, the average is 12, but you're right. We're starting to see that the bell curve is shifting, right? It's starting to shift a little bit younger and younger. And that a lot of times has to do. Now, I totally love evolution, and I love talking about evolutionary biology. And so a lot of these questions I think about myself, and I think, why would our body do that? And what's the purpose of this? And when our menstrual cycle starts, it means that our body has enough nourishment and nutrients in order to sustain not only itself, but also another person, right? And so, if when your menstrual cycle starts, it means that your body has received enough nourishment in order to do that. Now, obviously, and that's modulated by a hormone called insulin. Now, obviously, if there are more food and carbohydrates that we're being exposed to earlier on, way more, right, than what our body necessarily needs, then that clock is going to turn on earlier because our body thinks we're nourished enough in order to be able to sustain a whole other human being. Does that make sense?
Yes, that totally makes sense.
Yes.
I'm a 5th grade teacher, Dr. Salcedo, so I see this every single day. Like, when I first started 23 years ago, it was 1 or 2 girls And now it's probably half my class.
Yes.
Wow.
That they started their cycle because they have to come tell me, right? Like I need to go to the nurse. I don't have a pad, or whatever it may be. Or usually it's I can't do PE, and I'm like, sister, let me explain it to you. You don't get out of PE once a month for the rest of your life. I'm
No PE. Oh,
come to me for that kind of stuff. And so there's so many more girls now than it was even 20 years ago when I started.
Yeah, that's a shame, right? I think there's just such an overabundance of all of the food that we have, plus processed food 100%, you know, and a lot of folks will think about, and I actually haven't dived into the literature about this, you know, but you know, I know there are folks that have suspicions about hormones in our food and meat and, you know, or, you know, phytoestrogens or, what do you call it? Pesticides. I don't know, you know, I'm not certain that like there's enough to actually stimulate your the clock in your brain to actually say, oh, okay, you're actually nourished enough to go ahead and turn on that activation of the insulin that's required in your what's called the hypothalamus to allow the menstrual cycle to start. I don't know if that's true. I'm certainly open to you know reviewing the literature. If someone wants to send me something, I'm happy to look at it. You know, but from what I understand and from what we're seeing now, younger and younger girls, it has to do a lot with the problem of either obesity, overweight, or insulin resistance, because we also know that there's a difference between you know, some people who, and we know these people, right? You know, there's some person who like can't even look at a piece of cake and they get chubby all over. And then there's like someone who like, you know, eats like not great food all day and they're like thin as your finger, right? And you're like, that's not fair. Like what's up with that, right? And that has to do with like how our body expresses and processes glucose, you know. And so some people who are like super duper thin, those people who can eat anything actually have like some of the worst manifestations of diabetes, because all of their sugar is being circulated into what's called our visceral adipose, like our belly fat. But then there are other people who, when they eat any carbohydrate, their body does a really good job, but with using insulin and bringing it into their peripheral adipose tissue. And so then they just store it there. And so their blood glucose is kind of lower, but they store all the excess sugar into their adipose tissue. And so their organs are a lot healthier, but they actually have the damaging effects of what we call cytokines and prostaglandins, which are inflammatory molecules in the adipose tissue. So neither one are great, but it just depends on how we manifest. And so that being said, there are some folks who are like super, you know, stick thin, but they're eating too much sugar, even when they're really young in the peripubertal stage, or people who are really, really chubby and they struggle with weight, you know, in their peripubertal stage, and then like their puberty will start earlier and earlier. So the weight doesn't matter even in kids. So.
Wow.
You know, we received so many wonderful questions from our communities combined. And I also kind of want to know this. So when I was metabolically unhealthy, you know, fairly obese, I had very long periods between my menstrual cycle. I'm talking like 100 days sometimes. Like it was very, very long. And so we had a comment from shy.dheart5997. And they said, what is an abnormal period? Pain, cramps, PMS, length? When is someone to consider to have PCOS? And does and then they're wondering if you treat things in your practice with like keto and carnivore. We do know you do low carb, so that was
those are such good questions. I have a lot of the answers to those questions. Like, let's say if you don't get them all on my YouTube channel, shameless plug for my YouTube channel. But that being said, what is a normal period, right? So a normal period it lasts anywhere between 3 to 7 days. 5 days is usually best. Okay. And this is kind of a weird thing to say, where you bleed about 60 cc's of blood per period, which is about 2 shot glasses. And I know most people like bleed way more than that. Okay. And it should happen between every 21 to 35 days. Okay. From
I was
your
really
first
bad
period.
Ooh.
I know, right? From your first period to natural menopause, which is age 51 or so. Okay. So, so that's what a normal menstrual cycle is. Okay. And it's okay to skip here and there. Okay. And so, like, if you have a missed menstrual cycle every once in a while, that's okay. And here's another fun thing that we as women know inherently is, like, for example, I went to college. And so, you know how when you're in college, like when you go through finals week, there is like a very stressful time. And you may know people who've had like really, really stressful time and they miss a period, right? Like they're studying like crazy, they're super stressed out and they miss a period. Or there's a death in the family, or they broke up with their boyfriend and they miss a period. And everyone kind of knows, oh yeah, like I was super stressed out, I missed my period, right? And like a lot of people don't question that, and they feel like, oh yeah, that's like a thing. And it is a thing. And so, no, why is it a thing? Okay. Now, the reason why that is because when ladies are very stressed, okay, their insulin level also goes up also. Okay. So it's not just because of, eating too much carbohydrates, because there are so many things that cause elevations in insulin. And of course, carbohydrates are one of them, but also stress is super duper powerful. And your brain knows it, even if you're not going to accept it, right? So a lot of us, especially in my practice, I deal with a lot of women, and they always tell me like, oh, I'm not stressed out, but they have like a lot of stuff going on. And you're like, are you sure? Well, your body keeps the score. Your brain really knows. And so whether you acknowledge it or not, your body and your brain are always sensing to see what's going on. And so if your insulin level, it gets to a certain point, and it's different for everyone, but the numbers I'm starting to see in my own research is about 20. If your insulin level starts to go above 20 fasting, then it will likely change the clock in your brain to shut down ovulation. Now, why would it do that? Okay. Why? Well, it's because when you're all stressed out or there's too much going on, it's not a good time to have a baby. Okay. And the reason why, and believe me, I'm a professional woman. I don't believe that women were inherently made to have babies, but in biology, that's kind of how it is. Okay. And so if your body senses that you're under too much stress, it's going to say, whoa, dude, not a good time to have a baby. We totally have to shut this down until things get better. Okay. Now, because what happens, and I'm sure Ellie can tell us this, but when you have a baby, it's easily a 3-year commitment. Easily. Okay. It's like 1 year of being pregnant, and then you've got these little guys around for 1 to 2 years of breastfeeding and stuff. And so you can kind of get your life back, maybe. Okay. And so that being said, it's a huge biologic investment for us women to have a baby. And so if there's anything that's going to threaten our womanhood or our ability to take care of them, our insulin level is going to shoot up, and we're going to stop ovulation so that we can't. And then so if we stop ovulation, then your period won't come every month, right? And so so that's kind of what I teach women with PCOS, okay? And any stressor can do it. And so so that's why, like, when things are kind of stressful and life gets back to normal, your period will resume. But if you have more than 3 months of not a period, definitely check to make sure that you're not pregnant. And if you're not pregnant, well, then you should definitely go and see your doctor so that we can make sure there's nothing else going on. Okay. And so that's kind of the first stages of polycystic ovary syndrome, maybe, but it deserves a really good evaluation to make sure nothing else is up. So.
That was a great answer. So due to my age of 48 years old, Dr. Salcedo, I want to ask a little bit about the other end of that whole discussion,
Yes,
which
yes.
is perimenopause and menopause. I've heard, okay, so before I went keto and carnivore and kind of got into this community, it almost seemed like, it was like almost like a sickness that needed to be managed with, oh, you're going to be miserable, and you're going to have all these hot flashes, and you're going to probably need some treatment and maybe some hormones, and you're just going to go through years of, at the very least, uncomfortableness. But then I got, eating the way I'm eating now, and I've heard more and more stories of, well, the only symptom I had was my period stopped. End of symptoms. So I'm wondering, and that's just right, that's just anecdotal. So I'm wondering from a professional, someone who's eating, low carb or keto or carnivore like me, what are the chances that we're going to have an easier transition?
Yeah, that's a wonderful question. And what we do know in the literature is that the menopause transition, right? It's not just like a 1 day thing, or even a 1 month thing. It lasts about 10 years. Okay. And so it doesn't mean that you're struggling or suffering for that long, but the signals will start to change, and the full menopause transition will take about 10 years from the time that your brain starts getting reduced signals from your ovaries to the final time of 12 months of no menstrual cycle, which equals menopause. Okay. And so that being said, what happens is when there is declining estrogen, okay, from our ovaries, which are making less estrogen once we get into the perimenopause period, what happens is the fatty tissue from our hips and our butt area starts to change and moves into our belly. So our, excuse me.
Look at
So our tissue from,
Haley's like, no.
I know. And so when it moves into our belly, it becomes more inflammatory. Okay. And so because it's more of the visceral adiposity. And so the estrogen is like a really protective factor to prevent that transition from belly or from leg and bottom fat to our belly. When it goes into our belly, it becomes more inflammatory. And so then, of course, once we go through the menopause transition, then that is actually the time that our risk of cardiovascular disease equals that of a man. Okay. Before then, it's much, much lower. But once we hit the transition, it becomes higher because of that visceral adiposity. Now, what we do know is that visceral adiposity is very much modulated by insulin. Okay. So if you eat less sugar and have a really healthy lifestyle where you're chronically monitoring yourself or your stress levels, sleeping well, eating well, avoiding, cigarette smoke, tobacco smoking, anything, then your insulin levels are going to go down lower, and you're not going to have so much of a lot of the withdrawal effects that have to do with perimenopause and hot flashes in what's called the climacteric state, which is menopause. And so those hot flashes are modulated in your brain by, guess what, everyone's favorite hormone, insulin. Okay, so insulin is like, it keeps coming back. I feel like a broken record. I don't know about you guys. I feel like I'm saying this. We talk about this all the time. And so, yeah, and so those hot flashes are modulated in a special nucleus in the brain that are, modulated by insulin. And so if the insulin levels are low, then you won't have a lot of those hot flashes that people talk about. And then there's another protein called adiponectin, which also modulates all of these things too. And so when you have less fatty tissue, then you have more of a protective effect of something called adiponectin that reduces the annoying symptoms of menopause. So yeah, it is definitely very much modulated by our nutrition and our stress levels and stuff. And so we do know, and I hear it a lot from patients when they are keto, low carb, they have a lot less annoying menopause symptoms than a lot of other people. So
okay. when you're talking about Cristie, I'm going to go back to this, but the butt and the hip thing, I just have to know. Like, I know what is the evolutionary purpose of that? Because like in my brain, it makes sense that like if a woman wasn't able to reproduce anymore, that perhaps if that was evolutionarily correct, that like it was supposed to be that way, that like women's fat stores go to their belly. Is that to make them less appealing or make it, I'm just wondering, like for men.
I know. I feel
you don't have to like curve.
I know. I didn't want to say it. I'm glad you said it for me.
Okay.
And so, but I think so. I think it's because, and not because we don't deserve to look beautiful, right? But it's more of because, remember, like, evolution is kind of about keeping our gene pool going, right? And so if we're not menstruating every month, and there's no real way for our gene pool to keep going, right? And so, so I think that's kind of why. Is it a good thing? No, but it makes me think about like why like our little grandmas don't have a butt, and so
True. Well, it just makes sense to me because like, like way back before people were like, there was structure in society, maybe more so. It's like a man would be able to look at a woman and know if she was fertile or not, right?
That's
and
right.
that's my point. Not that like women who are older and have that are unattractive. I'm not saying that at all, because we all have mothers and grandmothers, and they're beautiful people. But I just mean on a purpose of being fertile, being able to mate with someone, and then, and same with, I'm sure men, I'm sure they get the belly too. I'm sure that there's something happening with them where women are like, no, thanks. It's not just women, but sorry, guys.
Yes. No, 100%. That it makes sense, right? And now it makes sense.
Yeah.
Yes. Okay, I want to honor anyone who's actually here live with us who has a question. So Diane just put this in. She said, I had a huge fibroid in the cavity of my uterus. I had to have transfusions because of the blood loss last year. I have now had a hysterectomy and would like to know your opinion about HRT.
Yes, it really depends. It depends. It really depends on if they took the ovaries at the same time of the hysterectomy, and your age, and if you've had risk factors. But I will tell you, with folks who have had their ovaries removed during hysterectomy, there are a lot of really good benefits to continuing hormone replacement therapy until natural menopause, which is around age 51. Now, there are certain ladies, who should not be on hormone replacement therapy, and those who've had like a blood clot in their heart or in their lungs. The women who smoke cigarettes or smoke anything, and also women who've had a heart attack or a stroke. Okay, so there are also women who've had certain hormone sensitive breast cancers or other cancers. They shouldn't be on hormone replacement therapy, or at the very least have a discussion with their oncologist. Now, that being said, women who had their ovaries removed early, or let's say are in the menopause transition, there's a lot of really great benefit for women to be on hormone replacement therapy. A lot of times it helps women sleep a little better. It helps with mental concentration and fatigue. It'll help with hair loss, unfortunately, that happens, or the skin changes that occur and stuff. There's a lot of nuance, to making sure that it's done safely. But the amount of hormones that are in hormone replacement therapy, and believe it or not, is actually far less than what a woman's body actually produced at the menstrual cycle, and the cycle monthly, and way far less than what a woman produced during her pregnancies. And so, the amount of hormone and hormone replacement therapy is really just a dab, and it does help with the transition, but it does lend to a very important conversation with a patient and her doctor. So, but it is very helpful.
Okay, thank you. There's a couple of comments here. Well, first of all, I'm going to put this right up. So thank you, Nia. I believe Nia joined Ellie's channel, and that is Ellie's. So I have to put that up there. Yay.
Thank
Ellie,
you so much, Nia.
Remember, that's awesome. Okay, and then a couple other people, there's not really questions attached to these, but they were just making some comments. So I bleed way more. I also have many periods between periods. I'm getting a hysterectomy in just under 3 weeks, actually. I'm tired of bleeding all the time. Do you see this a lot, Dr. Salcedo?
Oh, yeah. It's so hard. And so, I definitely don't want folks to think that the approach is only nutrition, and because there are so many women suffering silently. There are so many women who like can't go to like their cousin's birthday party or swimming or even work because they are so afraid to leave their home because they're going to leak or something, and so that is such a it's such a challenge. And even when I have like one heavy day on my period, I'm like, this sucks, like, and I can't imagine when women are going through that on a daily basis or years. And so that's why there are other solutions. But my big passion and my big driver is that just because that we can take a woman's uterus, which is sometimes a really important part of the treatment plan, doesn't mean that us as doctors shouldn't be able to be there for women to tell them how they got there. Okay. And it's not from a place of like, oh, your lifestyle sucks, like it's not that at all. It's mostly from a place of teaching and love and compassion and really telling the story about why the little blood vessels at the lining of the uterus became so inflamed. And sometimes a hysterectomy or medication is what folks need, because let's say, a woman who had a large fibroid uterus, really does, is bleeding terribly and having blood transfusions. Those are really serious things, and it's a huge quality of life issue. And no amount of keto or carnivore, to what we know so far, will dissolve those fibroids that will lead, that will cause a resolution, right? Because remember, tissue turnover and tissue regeneration takes years, okay? But the lining of the uterus is a regenerating structure, okay? That's really important, is that if you starting having heavy periods, even when you're a youngster, that's a sign, okay? The uterus is an end organ, and the end organ concept is when a person is exposed to the risk factors of cardiovascular disease, high blood pressure, diabetes, pre-diabetes, smoking, obesity, all of those things cause inflammation at the lining of the blood vessels, okay? And all the blood vessels feed every single organ in our body. Our eyes, we hear about diabetics losing their sight, or our limbs. We hear about people with kidney problems or hypertension, right? But the uterus is an end organ too, okay? And so the uterus is a recipient for all that inflammation, and even at the lining of the uterus. And so the lining will shed, and then you'll restart the next month. But if the lining of the uterus is inflamed, those blood vessels are inflamed, those tiny blood vessels will never contract well and stop bleeding when they should. And that's why people have these longer blood periods, because those little blood vessels don't constrict like they should, because they've been damaged. But there's time when you're early on in this, there's time, to kind of allow that to heal. And that's a big topic of my current research right now. But some folks, it's a little bit further past the needle, where maybe medications and surgery play a role. But here's the thing, just because we can take your uterus doesn't mean that the damaging effects of cardiovascular disease and the inflammation won't be there for the other organs, okay? And so the data shows that 1 in 3 women will get a hysterectomy by age 62. That's crazy. That's a lot of women. And it's not because of a female problem, right? It's because of an insulin problem. And so we really need to teach women that. And so wherever patients are, like I was saying, lifestyle, medication, surgery, I'm there with them, but we just got to teach them.
So Ellie mentioned earlier that we had a lot of questions, and so I'd like to read another one from Whitney. So she said, I would like to know if you, Dr. Salcedo, have had any patients with, she put it up, thank you, lipedemia, and if she sees a connection between that and infertility. I have lipedemia and tried for almost 6 years before pregnant. I know lipedemia is related to our hormones. Thanks, ladies.
Yeah, so the term lipedema can be for a lot of different things, but a lot of people talk about lipedema in the sense of inflammation at our fatty tissue all over. Okay, and so if that's what we're talking about, then the manifestation of how someone how their body reveals inflammation and insulin resistance is different for everyone, okay? And it depends on what your genetic makeup is and how your genes decide to channel that inflammation and insulin resistance. Now, some people, all of our bodies are fed, all of our fatty tissue is fed by blood vessels, okay? Now, if the microscopic blood vessels that are leading to our fatty tissue are inflamed, they are not going to, those little fatty tissues aren't going to receive the nutrients and things that we need in order to heal. And if they're inflamed, then they definitely won't work well. And that tissue and oxygenation and toxin transport exchange won't happen like it a lot of people. And how does this relate to infertility? Well, those tiny blood vessels also feed into our ovaries, okay? And so everything gets fed by these damaged blood vessels, okay? So absolutely, women who have lipedema, totally associated with infertility at the level of the ovary, because what do you need for ovulation? You need a couple of really good tiny blood vessels feeding the little egg that's getting ready to ovulate, okay? And if it's the integrity of those blood vessels aren't good, no amount of hormone replacement therapy, infertility treatments are going to make anything really healthy enough, because then you get pregnant and then the little conceptus doesn't stick to the lining of the uterus because the blood vessels at the lining of the uterus are inflamed, and that connection doesn't create a connection, a healthy connection, and then the conceptus falls off. And so that's why many people who have go through infertility treatments because of PCOS or other medical problems a lot of times will not get pregnant no matter how hard they try, no matter how many rounds of in vitro fertilization, because it's an inflammatory problem at the level of the microvasculature. So I hope that makes sense.
So
Yeah.
can I jump in really quick before I forget this?
Mhm.
I'm going to try to go about this in a very sensitive manner, but I'm wondering what your opinion is on like fertility in general, as far as an evolutionary standpoint comes. In your opinion, is it the person's body trying to, one, keep itself safe and healthy because there's something else going on? And then also, is it our the species itself as a whole trying to protect itself and have like, does that make sense? Like healthier children, healthier posterity? Is that kind of, as from an evolutionary standpoint, does that make sense? Am I asking it right?
Yeah, Hayley, I like how you're thinking, because, for better or for worse, not only does our body need to be healthy enough to receive a pregnancy, but it also has to be healthy enough to maintain and have a pregnancy outcome that is normal. And so, there's a lot of information to suggest that women with high risk pregnancies and preterm deliveries and cervical insufficiencies and all kinds of things, recurrent miscarriages, are related and associated with cardiovascular disease risk factors. Absolutely, and so, a lot of folks struggle with that, and those are really tough conversations because we have to approach them with so much love and care, right? Because a woman just really does want to, a lot of women want to procreate. They want to just have a baby and a family and stuff. And a lot of the solutions that we're describing, Hayley, have to do with a lot of self-reflection. They have to do with a lot of self-work, but also financial resources to be able to like cook, go to the grocery store, right? Like some of my patients are on SNAP benefits. Like I can't be telling them to go eat like keto and carnivore and stuff. They get 1 carton of egg a month, and so it's really tough. Or maybe they're working on like several jobs, so there are a lot of layers, but I think what we can all understand is that the place that we are currently in our modern society, in our industrialized nation, is not amenable to healthy women's lifestyle and our ability to have normal pregnancies. And so I really do believe that that's kind of why we're seeing so many obstetrical complications, because of the current health that women are experiencing. So.
That was going to be my next kind of on top of that. Do you think that kind of people who do have fertility issues, who are using means outside of themselves, like in vitro fertilization, I don't know what all of them are, but I know you do. And so all of those things, do you think that us trying to maybe trick people's bodies who aren't maybe as healthy. I'm not saying that everyone who has infertility is unhealthy. I'm just asking if your opinion is that that could be dangerous for those people if their body is kind of being tricked into carrying a baby when maybe it feels inside for some reason that that's not the right thing for that person.
Yeah, I know what you're trying to say. And I think those are really important questions. And so all we can do is point folks to the literature of what we know. And a lot of women that struggle with infertility or do advanced reproductive techniques, the data shows that they're higher risk for pregnancy complications, and so, but there are many reasons for infertility, just like you said, and not all of them have to do with metabolic problems. I mean, some people, have their fallopian tubes for one reason or another, or maybe their uterus is a funny shape, or maybe their partner doesn't have enough sperm or normal sperm and stuff. And so all of those things are really important to acknowledge. Or maybe they had cancer when they were little and they had eggs harvested. I mean, there's so many reasons why the infertility community is very beneficial to where we are, and we're so lucky to have that. But there are a lot of folks sometimes when those issues are not really at the forefront of the cause of infertility, it's just hard. And we just have to have really honest conversations with patients about proceeding with treatments and under having a good conversation about risk benefits and alternatives. And then the patient gets to decide, And so, and it's just all about having that teamwork approach, and really informing women about the potential risks, if at all.
Thank you for answering those hard questions. And nobody come at me. I'm sorry. I'm sorry if anybody.
Those are really good questions. That's really good. Yeah.
So I was kind of curious because you obviously are positive about keto and carnivore and being low carb. If, say, you had a patient that was having some maybe issues with their menstrual cycle or getting pregnant, like what would you suggest for them to change in their, what would be your recommendations to change their diet with? Like, what would you suggest to them?
Well, it just depends. It depends on what they've tried. It depends on what they like. And it really is important to have a longer conversation about all of their inflammatory factors. A lot of folks say, hey, like I tried low carb or keto or something and I hated it, or like I had such bad joint pain for like the first week that I couldn't get through it, or I was throwing up or something. Well, a lot of times that's keto flu, right? And so if you kind of teach folks about a lot of the negative side effects those first few weeks when you're turning into keto metabolism, and you kind of walk with them safely, and I do really believe that ladies who are trying to go low carb or keto or carnivore for those first few weeks really do need to be under the supervision of someone who really knows what they're doing, so that they can teach people, because it can be kind of scary, or if you're on certain medications and stuff, it can feel really weird. And so but a lot of times what I do is I take an assessment and inventory of like their inflammatory factors. I talk about sleep and family history and whether they snore and what kind of food they eat and if they have any supplements. And we talk about everything. And then I teach them kind of like inflammation and insulin resistance, and then we do some blood work and we look at vitamin panels and insulin levels and those kinds of things. And then we look at ultrasounds and we kind of develop a plan, and so sometimes the answer isn't always at that first visit, but maybe the second or the third. But my goal is to really guide women to understand that bringing down their insulin level, if that's really the cause of a lot of their irregular bleeding, is kind of the North Star. And so if that is something that we can do, it just makes sense to reduce carbohydrates in a very intentional way, but also other things that are causing elevations in carbohydrates too. I mean, I know that like if I get stressed out, like I start to see it like in the heavier period and things like that. And so even though I don't really eat too many carbohydrates, like stress is very, very much like a part of my life. And so that helps. I like not being on birth control because it really does help me as like a compass of where I'm at, and I'm like, oh, okay, I have to make too much take some adjustments and stuff, but depending on what folks are interested in, let's say they are kind of already low carb and they want to challenge themselves with keto or even carnivore, I think that's cool. It just depends. But I try not to start people on carnivore right at the beginning because it can be really abrupt, but some folks are like, I've tried everything. I just want to like rip the Band-Aid off. And I'm like, okay, that's cool. Let's do it. So it just depends on where they're at.
Thank you.
Yeah. So that leads, so when you were talking, it sounds like you have the ability, I mean, from your answer there, that you have the ability to spend some quality time with your patients. How long would a typical appointment be? Because I'm like,
that's probably why my clinic's always late. And so my poor patients are waiting forever. And so, but send me some prayer and good thoughts because I am really starting to position myself with a telehealth consultative practice in a part-time fashion because I really do feel like women I think there are a lot of folks who would appreciate my consultation and love their gynecologist, but maybe their gynecologist doesn't have enough time, to kind of go through this. And so, I would love to walk with women and help their gynecologists with tease this stuff out too. And so almost like a consultant to your consultant. And so in my dream and in my planning for this year is to do that. And so, I've already talked about it with work and things like that. And so everyone kind of is trying to support me. But yeah, I mean, a lot of times, believe it or not, I try to get through this in about 45 minutes with my first new patient, and then everything after that is about 15, 20-minute visits, little fine tuning and stuff. But truly, I feel like once you get people to understand the biology, it's easy after that, and then it just like the patient gets to decide how far they want to take it. So.
Okay. Well, we have another question that popped in here from Dr. Nelson. Loaded question coming, so you've been warned. In terms of infertility and women's health, should women prioritize maximum possible metabolic health or versus just weight loss?
That's a great question, and it has to do with the manifestation of how women process their insulin and their glucose. Now, remember how I alluded to the peripherally obese person and then the viscerally obese person, so the thin person, right? And so if we're having metabolic health as our North Star for this, it doesn't matter if when people are super thin or struggling with weight because the goal is going to be the same, right? I'm a person who is the viscerally obese person where when I was a pregnant patient, I had gestational diabetes. My glucose test, my 1 hour glucose test, that drink that we have to drink, it was 200. Okay. And I didn't even have to do the 3 hour test. Like they were like, okay, you're done, and I'm like, what the heck? I'm 126 pounds. How did I get gestational diabetes? Well, I'm the viscerally obese person where it laws in the middle. Okay. And so people were really surprised. And so the thing is that with, insulin resistance and low carb dieting, it's important to remember that it's not about the weight loss because you can be fooled by a TOFI, a thin on the outside, fat on the inside, like me. Okay. And so I'm a TOFI. TOFI, thin on the outside, fat on the inside. And so, you just kind of have to know who's in front of you, you know, and people will tell you, oh yeah, I eat a bunch of junk and I never get chubby. Everybody knows who that person is. And then there's other people, I can't even look at a piece of bread and then I get chubby. Well, yeah, like, so Dr. Vasquez, you know, I would just say that prioritizing metabolic health is really the forefront. It doesn't matter who's in front of you. The treatment is the same.
So that leads me to a personal question then. So you're a TOFI. Was that before you went? I don't exactly know your diet, but so before you went meat-based or low carb or the diet that you're currently eating, and do you have like DEXA scans or something? Has that improved?
I know it. I'm definitely thinner. I was thin, but I carried it kind of more in my belly, and I just kind of felt a little swollen. I was more swollen, and now I see pictures of myself, and I'm definitely more defined and stuff. And also, I'm trying to gain more muscle. But you know, I don't do DEXA scans. It's not indicated in someone like me, you know. But yeah, you know, I did get leaner, but not like underweight lean. So yeah. And I'm kind of like, it depends. I was telling Ellie at the break earlier, I'm more of a low carb person because I like vegetables with butter. But you know, some weeks, like when I'm really, really trying to be efficient, like I'm more meat based, like completely meat based, but I swing back and forth. So
yeah.
Can anyone else relate to swollen? I can relate to swollen.
Oh my God.
Oh, it was so bad. Literally had like a moon face. I was moon in the sky.
Yeah. Well, I like what you talk about being a TOFI. I don't know. I think I was like in between. I feel like I was in between like someone who seemed larger or obese and someone who was really thin. Like I was like right in the middle, and you're like, that lady's unhealthy. Like I know people thought that, but Dr. O'Mara, he talks about like the MRI scan and like how he'll have even vegans who are whole food, plant-based, no oil, none of this stuff. And he's like, they're so viscerally heavy, you know, but they just look like these little skinny poles. And so I have to break that in my brain. That is like the hardest thing to break is the scale going down means health. Like it's not true. It's not true. And so anyway, I love that you said that, a TOFI.
A TOFI, yeah.
So I don't know if this falls under your expertise, but there was another question that we got about like bone health in menopausal women. Do you have any recommendations like to keep, you know, from losing our bones?
Yeah, you know, such an underrated organ that we should talk about more is our muscles. And so there is such a phenomenon called sarcopenia where you start to lose muscle mass, and that starts at after age 40. And so 10% of your muscle mass will just go down no matter what. And so muscles are really, really important. They're a great place to store glycogen, you know, and you know, our sugars in our body and stuff. But also trying to increase muscle mass, particularly in the perimenopause, will increase our bone mass and our bone density. And so that's a really important thing. It's something that I'm trying to do. I'm in my mid 40s. Like I'm really trying to, you know, lift weights and stuff, you know, and so to prevent that. And but yeah, you know, and then of course we do know that estrogen does help with bone density as well, although it's not a hormone replacement therapy for the treatment of osteoporosis is not approved. It is still something that makes sense in terms of bone health. And we do see people who feel like when they are back on hormones, they feel that their bones don't hurt as much and stuff. But yeah, I think just, you know, really increasing that muscle mass is really, really important in menopause. So
I had a question as well, just so that we don't miss it. This is from someone else as well. Does she recommend hormonal birth control for young women? Are there any caveats to it? Length and treatment, effects on fertility? And I also kind of wanted to just throw in a plug here. I don't know. I know you said you were pregnant, so you have kids. And I don't know if they're boys or girls, but I was wondering how you would.
Mom.
Boy mom. Okay.
I got 3 boys.
Yes. If you had a daughter, what would your approach be to as far as like, birth control, would that be something that you would recommend to moms in general? Or, would you do like more of a natural, like her learning her cycle type of experience?
Yeah. Oh, here we go. This is a long question. No, just kidding. Yeah, this is a good one. And so personally, I don't use hormonal birth control because I really like to be attuned with my cycle and try to learn about what my lifestyle is doing to my feminine health. Number one. Okay. Now there are some folks where for religious reasons and stuff, they prefer not to use hormonal birth control or anything that suppresses, prevents ovulation or impairs like the implantation, and that's cool too. We take folks for where they're at, and it doesn't really make a difference to me, but I also try to teach people the mechanism of action of things. Now, in terms of hormonal birth control, typically a lot of women think about is like the birth control pill and stuff. And so, and which is very safe. Okay. There's a lot of bad stuff out there and stuff, but there are certain folks that shouldn't take hormonal birth control. I alluded to some of them earlier. Also people who get migraine headaches with aura, which are like vision changes and stuff, shouldn't be on hormonal birth control. There's a lot of other things too that they should talk about with their doctor. But there is some discouragement of using a combined hormonal contraceptive therapy, which means estrogen and progesterone in adolescence and before their bone plate has closed, because being on low doses of, and this sounds kind of weird, so listens carefully, being on low doses of or any birth control at all will suppress ovulation. Okay. And if it suppresses ovulation, then it reduces the amount of estrogen that supports your bones. Okay. And it can lead to lower bone density. And so everyone's like, oh, I want the low dose pill. And I want, but you have to be really careful, because if you're on such a low dose, then your ovaries will stop producing or decrease the amount of estrogen that's produced. And then you run into concerns about your bones. Okay. And so, there's good reasons to be on low dose birth control, and there is not good reasons to be on higher dose also. And so it really just depends on who's in front of you. Now, if I had a child who was a girl, and would I say that you should be on hormonal birth control? It just depends. It depends on the goal, right? And so let's say you got a honeymoon coming up and you're like, I absolutely don't want my period. Well, sure. Be on hormonal birth control. That's just fine. But I do think that understanding the essence of our womanhood is important for physiologic reasons, not just like, religious reasons are important too. I'm a Catholic, but I do think that, outside of like the religious realm, I do think it's important to teach women that their menstrual cycle is a vital sign, and if there's something going on, if it's heavy, too painful, where you're like popping Motrins, ibuprofens every few hours, that's not normal. Okay. And so I think that we should be embracing it and using it as a gauge for lifestyle, even though it's kind of an annoying thing, but it really does help us slow down. It helps us be a little bit quieter and give us maybe the break that we really do need. So, yeah.
I've learned so much tonight. Thank you so much. Oh my gosh.
My brain is exploding.
I'm gonna have to rewatch this and then take notes so I can like really absorb everything that you've shared with us tonight. I would love to shout out your channel. Can we do a little shout out?
Oh yeah, thanks.
That's great. Your channel is great.
All right,
yeah, it's super cool. It has a lot of the stuff that we talked about in small bite-sized things. And oh yeah, there it is. And so, I'm gonna do a couple videos next week, so look out for those. But it's so much fun, and these are things that I talk to my patients all the time. A big topic right now is endometriosis. It's really what a lot of my videos are getting a lot of play, and I love talking about endometriosis. We can do another show on that if you want. But that's a whole other animal. And
please
stuff.
come back.
Yeah.
Yeah,
We
so-
literally have so many more questions. It's not even funny. Like I'm just sitting here like scrolling through like, what do I want to ask right now before we end?
Well, subscribe so that more folks can, get the word and I guess the algorithm or whatever, but I'm not trying to make any money off of this. I'm just really mostly trying to spread the word about gynecologic health and to really embrace, because not that I'm trying to say that birth control pills are not a good thing, but they really do mask potentially a lot of the concerns that might be revealed to us in our menstrual cycle that we need to pay attention to. So
well, we just want to take this opportunity to thank you so much for coming on. And I appreciate that you were like willing to already come back. So we're going to invite you back. I'll be emailing you. I probably won't have jury duty next time.
Yay, good.
Yes.
That would be nice.
Okay, well, I'm trying to get to 1,000 subscribers. I'm almost at 1,000 subscribers. So hopefully you guys can. Yes. So
okay, she's almost to 1,000. You guys, come on, let's
yes, get in there.
I hear that's
I put her link.
Yeah,
it is. I put your link to your channel down in all of our chat rooms so that everyone can give you some love.
Yes,
you're getting a few. You're getting a few.
Yeah, Deb. Dr.
Hey
Nelson
guys!
also.
Awesome.
Yay.
Well, what an honor. Thank you so much.
Yeah, and thanks everyone for tuning in to us on a Monday. Tomorrow's episode, we're gonna do like a Lioness Q&A. So that'll be so fun. We hope you'll join us again tomorrow for that. Look at this, we got two more. We got Mike Shaw. Oops, and
sorry, who's me?
Sorry, we're battling over the button.
Yes.
Yeah, and Renee is number 8.
Thanks for the support, you guys. That's so awesome.
I know, and I'm going to be subscribing all your channels too. It's super exciting to meet everyone, and I think I've done a lot of talks, and there's a lot of stuff on like Low Carb USA and things like that I've lucky to be a part of. Nutrition Network is another wonderful organization that does a lot of really great medical content. A lot of doctors and healthcare providers can get continuing medical education, but also lay people can check it out. And we did a really great women's health elective that I helped spearhead. And so please, 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 share with your doctor. It's important to kind of share this stuff. And it's an honor to be here. So thank you very, very much. And I'll send you guys our latest paper that's coming out that looks at abnormal uterine bleeding with insulin resistance too. Really exciting stuff. So
yeah, we'll put a link to that down in the show notes too after this is over. So if that's okay with you, so people can access it.
Sounds great.
All right. Well, Hayley, are we gonna roar, or are we just gonna?
Do you want to roar with us?
I don't know if Ellie warned you about the roar, Dr. Salcedo.
Oh, no, I forgot.
Okay. Am I a lion? Am I a lioness right now? Are we?
Yes.
Didn't you do the intro? Yeah, didn't you remember the intro? You are totally a lioness right now.
It's okay. You can do a meow too. You can be like sassy about it. Okay, guys, get those ready. Put them in the comments. Okay. All right, ready? 3, 2, 1. Yay!
We did it. Oh my goodness.
Yay! Oh, Renee put burr because it's freezing.
There's some roar. There we
Mike,
go.
Thank you.
Thank you.
Ooh, we got a meow.
Oh, that's good.
Oh, yeah, we love it. We love it.
Garar. That's pretty good. I like that. Oh, here's yours, Cristie.
Yes, picanha is my favorite. I love picanha. There we go. We gotta have the picanha.
Oh, I love it. Thanks, you guys.
Make my day every time you do that, Eric. Thank you. All right, everybody. We'll see you tomorrow.
Bye. Thank you.